Hi, good evening, everyone, and welcome to tonight's webinar. I would like to acknowledge the traditional owners of the respective lands upon which we are all meeting, and I pay my respects to elders past and present. I'm pleased to introduce our presenters for this evening, Professor Paul Effler, and our facilitator this evening is Dr. Ramya Rahman.
Paul, thank you so much for joining us this evening.
Thanks for having me, Ramya. And I have to say that talking to GPs is really important. For myself personally and for the health department, we recognize you are the front line of treating potential patients with COVID and also our prevention efforts through vaccination. So this is a real opportunity for us, and I thank you for it. Before we begin though, this is NAIDOC week, and I noticed the theme is Heal Country and how appropriate for us in the health profession. So I'd like to acknowledge the Whadjuk people of the Noongar Nation, the traditional custodians of the land and their resilient custodianship. And I pay my respects to elders past, present, and emerging. And if there's any Aboriginal or Torres Strait Islander people on the webinar tonight, great to have you here. Thank you. So first of all, I'd like to say, I think this is important when you're giving a talk about immunizations to let people know I have no stock holdings, and unfortunately that means no stock holdings. I've used that joke a lot, but it's true. No pharmaceutical affiliations and no pharmaceutical payments in my background. What I'd like to do tonight is fairly quickly go through essentially three topics: what we know about the Delta variant thus far, what we know about vaccine effectiveness against the Delta variant, and then I'd like to shift gears a little bit to what I think is an emerging topic, and that's the data that's coming out on mixed vaccination types of vaccines, mixed schedules with them, and what we know coming in from overseas. Again, if there's a busy slide, I'm going to try and lead you to right to the part that we need to consider tonight. And I've tried to list the websites and other places where this data comes from if you want to go back later and look at it yourself in more detail. So what is the Delta SARS-CoV-2 variant, and is it more transmissible, and is it more virulent, I think are the major questions facing us. And about the variant, and it's one of four variants of concern. There's variants of interest, but the variants of concern, as you might recall, we started with the one from the UK, which was known by the alphabet soup there. We were numerical soup, and now we've changed to using, Greek letters, and so that's now Alpha, the strain that emerged in the UK. Beta was the previous, what was called the South African strain, and Gamma, the Brazil strain. And so this is our fourth one of these variants of concern to be designated by the World Health Organization. And so what is a variant of concern? Well, the World Health Organization defines that as when there's been changes to the virus that either increase transmissibility or there's other detrimental changes to the epidemiology. And for me, that would be if we saw more serious cases in children, for instance, something like that, even if the transmissibility wasn't higher. Or there's an increase in virulence or a change in the clinical disease. Obviously, that would have us concerned. Or if there's a decrease in the effectiveness of our public health and social measures, or our available diagnostics, vaccines, and therapeutics. That's what defines a variant of concern. So this Delta variant is been identified as such mainly because it's got two mutations, and two important mutations, and some people call it a double mutant. And that, of course, sounds a lot scarier, I think, when you say it that way. But essentially, it's the two shown there. You're looking at the spike protein from above, and it shows the E484Q mutant, which is essentially you're switching amino acids at a given site, and the L45-2R switch of amino acids as well. And these are anticipated or have been shown to potentially increase binding to cell receptors and also then the ability to fuse with those cells. And that's why the concern, also perhaps an enhanced ability to not be targeted by antibodies to the original strain or the strains that are contained in vaccines. So that's what we're talking about when we say a variant. When I say double mutant, that's actually a misnomer. There's at least 13 amino acid changes, whether they're omissions or changes in other places, seven amino acid changes in the spike. And now we've even gotten to Delta plus, which is if there's a mutation in the K417N location as well. And that's believed to potentially aid in virulence. It's been seen in other variants of interest but we don't really know how that's going to behave going forward. But it is not the dominant Delta strain right now. So where is the Delta variant? Well, it's everywhere now. This is data from the WHO, their weekly epidemiological update. You can see in small print there, published the 6th of July, so 2 days ago. And it's all over the world. It's been detected. You see Australia's lit up in lavender too. I mean, we've had cases of it, certainly not like some of the other jurisdictions, India, the UK. And I saw today in the news that it's now the dominant strain in the US with more than 51% of the cases being Delta variant. So worldwide, and most of the data I'm going to show you tonight is coming from the UK, where there's been a fair amount of study of this variant, but I would anticipate we will see a similar work coming out of the United States very shortly as the dominant strain. So who's getting the Delta variant in the UK? Well, this is the age and gender distribution for the population of cases so far of Delta. And you can see that a big chunk of these individuals are under 50. I would guess that's about 75% or more, and even under 30, maybe half. So a lot of younger people are getting Delta variant, and that could be a couple of reasons. It may be they're less vaccinated. It may be they're less adherent to social distancing and other non-pharmaceutical interventions to reduce transmission. These data with a preponderance of younger people will affect some of the information I show you in future slides. So where are people getting exposed to Delta in the UK? Well, the UK has a system of trying to identify where somebody acquired their infection. And this is what they've produced for Delta. This is one of their standard reports that comes out. And you can see it's got the dates along the bottom, and then it's got these bars of different color. And starting at the top, sort of the maroon, what on my screen is some kind of odd green, and then a dark blue. Those are all school settings, education settings. You can see that in the legend at the bottom. And they account why schools were open for about 75% of the transmission for Delta variant. And then you can see that goes down proportionally as schools in the Northern Hemisphere wind down for the summer break. So that's Delta variant. Well, what about Alpha? Where did people acquire Alpha during this time period? Well, that's the same information for Alpha. And when I look at those two plots, tables, graphs, whatever we want to call them, I can barely tell the difference between them. So it looks to me like it's pretty similar transmission exposures for transmission for Delta that is also the case for Alpha during this same time period. So not a dramatic difference in my opinion in that regard. So then again, I'll mention here the technical briefings. This one is from the 25th of June. It's the most recent one from the UK, and these are very good if you want to get more detail. But to try and address is it more transmissible? Let's look at the information they provide in this report. And you just have to look at this and see the Delta variant, how it takes off, starting in April, and by mid-June is absolutely dominant. So it's basically run the other strains out of existence. It's a fitter variant, and it is taking over transmission. And if we look at it another way, is it more transmissible? This is a graph from that same report that shows after the first 5 cases, how long does it take to get to certain levels? And that lavender bar is the Delta variant as it takes off. And that's not a linear scale, by the way, on the y-axis. So you can see it's really quite dramatic, the spread that it's had. Then again, it's hard to know, is that because it's so much more transmissible, or is it getting into a younger cohort of people who are not vaccinated and who are not socially distancing? How much does that contribute to its trajectory, I guess is the question. So one way you can look at that, and again, this is data from that report, is you can look at household contacts and other contacts and look at the secondary attack rate that's occurring there. And that's just what we have in this data that the UK has provided. If we look at the secondary attack rate among household contacts, essentially we see for Alpha, it was 8.6% of household contacts become a case. And for Delta, it's 12%. And that is more, about 3.4% more. But I think might surprise people that one, that household contacts with either COVID strain, more of them aren't infected. And especially with a highly transmissible strain, we're talking about 12% of household contacts, which is just a little bit higher than it was with Alpha. And then again, if we go to the non-household contacts, we see generally transmission is lower, 4.6% for Alpha and 6.6 for Delta. So I can't vouch for the absolute accuracy of these figures, but they're obtained in the same way. So it would suggest that the relative difference we're seeing is probably a reflection of reality. And so again, in my mind, that says it is more transmissible among contacts, maybe not such as big as increases I would have thought from reports that we hear. Then the second thing we can look at to think about, all these cases that are occurring, is it reinfecting people that have previously had COVID? And so in the UK, they have a program where they follow, almost 10,000 people that have a known previous COVID infection, and then they see if they get a reinfection. And this is that data spread out over a calendar, and it's just the number of reinfections in that cohort of about 10,000 people. And you can see when Alpha was dominant, there were actually quite a few more secondary cases picked up. And that could just be because there was more Alpha at the time and we're not to the peak of Delta yet, and that may change. But if you look at the time when Delta is dominant, we're talking about 5 reinfections out of this 10,000 people so far. Again, everything I say tonight, this is a rapidly moving space. And what I'm trying to present here is the most recent data, but I recognize things could change as new data come in. But right now, that data would not support that Delta is causing a lot more infections by reinfecting people who would have some previous antibody from a previous infection. So is it more virulent? So that was about transmission. I'd say, yes, it is more transmissible, but how much more I think can be discussed. But the real question is it causing more severe disease? And I think this whole issue arose because initially a study in Scotland, or a data analysis in Scotland, found that if they matched you well to other people, folks that had Delta strain as opposed to Alpha strain were close to twice as likely to be admitted to hospital. And this study was repeated in England, and there they matched for age, sex, ethnicity, area of residence, deprivation level. The week the specimen was taken, that accounts for intensity of infection pressure, your vaccination status, and whether you traveled overseas in the last 14 days. So they matched on a lot of things. And they also found that you'd be twice as likely to be hospitalized with the Delta strain compared to Alpha, and go to an emergency department or be hospitalized about 1.5 times as much. So what that says to me, on an individual level, if you're matched for everything else, Delta strain might make it more likely that you're hospitalized going forward. And that's an important fact, and we shouldn't dismiss it. But we also need to look at, that's on an individual level, the population level. What is it doing as far as disease in the community? As far as, maybe that's a public health doctor but I think we need to assess that to see how severe we can expect or might anticipate Delta being. So this table is also provided in the report, and it's very busy, but it looks at the proportion, the percentage that go to emergency department, the percentage that get admitted, and the percentage that die. And I've cut this down today to just be where the action is for us tonight. And so we're going to look at ED visits, hospital admissions, and deaths. And we're going to compare Alpha and Delta in their percentages. And this is just cases overall. And you can see that there's quite a few, more than 100,000, almost 150,000 Alpha variants. And there's some 90,000 Delta variants in this analysis. So it's big numbers. So let's look at people under 50 in these two groups, Alpha versus Delta. Well, for people under 50, you have about 5% chance of going to an ED if you have alpha, and about a 3% chance if you have delta. And you got a 1.4% chance of being admitted if you got alpha, and a 1.1% chance if you have delta. And this is all people under 50. And then if you look at deaths, you have a very small chance of dying from alpha, but you have a 1 in 10,000 chance of dying from delta in this big study. So 8 out of 82,000 people died who were under 50 years of age. So very, very low death rate. And again, doesn't harbinger very severe disease in the young. So let's go to over 50s. Again, we see the same trend. Twice as likely, 14% to go to an ED if you have alpha. Almost twice as likely to get admitted if you had alpha, and maybe 4 times as likely to die if you had alpha compared to delta. Again, that's people over 50, and maybe a lot more of those delta cases were on the younger side of that being over 50. So that is a problem in interpreting this data, or a caveat in interpreting this data, but it doesn't really strike you that there's any evidence there that delta is more virulent with this aggregated data. The other piece of information on a landscape view, this data was presented by Dr. Ramsey at the National Immunization Meeting here in Australia last week. And she's very involved in the COVID vaccine rollout and the COVID epidemiology, quite a scholar. But here she shows the number of people in hospital each day in the UK going back from September. And what you see is, when you get to June, where Delta's dominant, the hospitalizations are quite low. So it's an interesting picture with some, regression data suggesting an increased risks, but clearly overall, Delta is not having the impact that, say, Alpha did in January and February, at least not yet. And then again, if we go to the case fatality rate, we use that often in epidemiology to look at severity. And this is all the cases available in this analysis. Again, we see the same thing. The case fatality, and this is for people that have at least 28 days of follow-up. So they've had an opportunity to get, unfortunately, very ill and die. You can see it's about 2% for Alpha, and it's about 0.3 for Delta. Again, that would suggest that Delta does not appear to be especially lethal. And again, I really, that's deaths attributed to the virus, but that relies on having access to testing and wanting to go get a test and everything else. So I really like all-cause mortality for trying to figure out what's going on, particularly in a pandemic like this, because all-cause mortality looks at whatever you died of, you get counted. And death is a state that's easily recognizable. It's recorded really well in most countries of the world. And so it does have a place in looking at the impact of a pandemic. It'll also pick up people that might die because they didn't go to the doctor to get their preventive care, or they delayed their cancer therapy. So it just really looks at the impact overall. And this is this is from a website called Euromomo. Again, you just type that in, you'll find it online. It's an amazing website for Europe, all the mortality data from participating countries. And what you see there in the UK, they had a major spike when COVID first broke out there, in the initial wave. They had another big spike with an Alpha variant during the holidays, December, January. But there's no evidence right now to suggest that they're having increased mortality with this surge in Delta cases. And you can also look at the Northern Ireland, Scotland, and Wales, and they've had even less impact from both viruses, really. And
well, I might just jump in there just with a couple of questions, if you don't mind. It's with regards to the data that we've just seen with regards to the UK. Do you think the data that's showing the low fatality rates is because of the high vaccination rates in the UK?
I think that's helped probably, but a lot of the cases are in younger people who aren't vaccinated. So, and that's what people are saying, well, we're having more cases in young people in part because they're not vaccinated. So in that, that analysis will be done, but I don't think that that's explaining it in the youth. But I will get to the effect of vaccinations on serious disease in a couple more slides.
Thanks, Paul.
And then this is just looking at all of Europe, the countries that participate. And you can see only Belgium and Spain have a slight excess in deaths. Every other country has normal all-cause mortality, and they have for a long time, again, suggesting that this Delta virus that has emerged has not greatly impacted deaths overall. So then my last issue with slide on severity is this. This is a system called the Zoe COVID symptom study, where they have people record their symptoms after they're diagnosed with COVID. And essentially what they're seeing now with the Delta strain is that the profile of the symptoms has changed. And what we have more now is headache, sore throat, and runny nose and fever. So cough is now rarer than it used to be. And if you look down here to the way down at the bottom here, it says that shortness of breath has now dropped to number 30 on the list of symptoms reported. So again, in an outpatient environment, this data does not necessarily suggest a more serious illness. So what's the summary on this? If we look at the Delta variant, well, I was going to summarize it myself, but I just thought, well, let's go with the experts. Let's go with WHO's assessment. Again, from 2 days ago, looking at Delta. For transmissibility, they say, yes, increased transmissibility and secondary attack rate. And we saw that with the data that's been provided. But on disease severity, they say not confirmed, and that it is possible that it's an increase in hospitalization related to it, but based on the data that they've been able to see. Risk of reinfection, some neutralizing antibody reduction, but again, it doesn't look like it from the data available. It's a major impact and no impact on diagnostics. So that would be my assessment of the existing data for Delta. Well, do our vaccines protect against it? And the good news is yes, particularly well against severe disease. Again, this is from a preprint that is in the works, but I imagine it'll make it. You can see Mary Ramsey's the second author here. And essentially, I'll walk you through it. If we look at the Alpha variant and Pfizer, there's 95% protection against hospitalization. And for the Delta variant, 96%. I don't make any matter of those small differences, but very good protection. And for AstraZeneca, the same really, 86% against hospitalization against Alpha and 92% against Delta. So that's fantastic news for us against hospitalization. The two vaccines we have in Australia seem to work really well. If we go to symptomatic illness, however, so less severe illness, and we look at those same data, you'll see for Pfizer, it's 93% against Alpha, and it drops a little bit to 88% against the Delta strain. A bit of a drop, not huge. Confidence intervals overwhelm. For AstraZeneca, it starts lower against Alpha at 66%, and it drops to 60% against the Delta strain. Again, that's any symptomatic illness. So if we look at that graphically, again, this data provided by Mary Ramsey. If we look at dose 1, both vaccines against Alpha are below 50%, and they go down even lower into the 30s for Delta. So one dose is not panacea in any way. 2 doses, though, we see that lift in Pfizer getting up into the 90s for Alpha and high 80s for Delta, but we do see a statistically significant reduction in protection provided by the AstraZeneca vaccine against both the Alpha, but even a more bigger drop against Delta, ultimately. So what do I say about this? Delta in general, if I had to sum it up, I'm thinking that some of our rhetoric and some of the messaging we're putting out about Delta may not be supported by the facts as they exist today. And so this is from Nature, right? A very esteemed journal. Scientists brace for impact. That would give you the impression that we were headed for a catastrophic crash. Even though, it says it's just about transmissibility there, that certainly the headline communicates a different message. And here in Australia, just lots of stories. Are we ready for the Delta variant? If you watch the news at night, it's like, well, this new Delta variant, like it's something completely different that we have not seen before. And this is just from yesterday. 8 young adults in New South Wales hospitalized with COVID as the Delta variant spreads. And it talks about the big proportion of young people in hospital. And this is a quote from Dr. Kerry Chant, the chief health officer. The Delta strain is not a mild disease. It can be mild in some, but for many, it can lead to hospitalization and death. And I really question if you're talking about, 1 in 10,000 for people under 50, whether that is a justifiable statement. We also have this other professor saying this form of virus has a counterattack measure. It's using stealth. So we're getting into the realm where we're ascribing human traits to a virus that's just passively mutating and letting natural selection pick its outcomes. And I think this is somewhat dangerous because I think it essentially causes undue concern amongst the population, and that is certainly not our goal. So my summary of what we should be doing with the Delta variant is paying close attention and trying to make sure we're getting everyone vaccinated with the best vaccines available. And after that, just recognize that the sky is not falling with this new variant, and we need to pull back from some of our rhetoric, in my opinion. All right, so that's it for Delta variant in vaccines. What I'd like to talk about briefly is mixed data, or mixed emerging data on mixed vaccine types. Well, it could be mixed, you'll see. This data really just came out in the last week with the ComCov study done in the UK, which they were planning for times where maybe we wouldn't have a good supply of every vaccine and we might need to mix and match, but it's become particularly relevant with developments of adverse events in certain vaccines. And so what they did is they took, roughly 800 people, and first let me give credit to Matthew Snape, who presented this at the Australia Immunization Conference last week, and lots of this data is coming from his presentation. What they did is they took people and they gave them two doses. First was Astra, then second dose Astra, then they had Astra and they switched it to Pfizer. And then they had Pfizer like it's recommended, and then they did Pfizer and followed it with AstraZeneca. So essentially they have 4 arms in the study, and this data is looking at what they found at the 4-week time point. They had a 4-week interval between the 2 doses, not necessarily the 12 that's been recommended. That data will come out farther down the road. And they had 3 things they evaluated it in. What's the level of spike antibodies, the spike IgG? What does it do to using pseudoviruses, so not live COVID viruses, but pseudoviruses presenting the antigens? How does it perform against that? And then what's the cellular immune response, cell-mediated immunity response? And so this compares Astra to Astra Pfizer in this graph. And what you see is if you have a AstraZeneca followed by a Pfizer, you get almost a 10-fold increase in the level of your anti-spike IgG antibodies. And if you do neutralization with the pseudovirus, essentially you get a 10-fold higher neutralization with the mixed schedule of Astra followed by Pfizer. And if you look at the cell-mediated immune response, you get about a 4-fold increase in response. So that really suggests that Astra followed by a Pfizer it gives better protection, or I should say correlates of protection or indicators of potentially future protection than Astra. Well, what happens if you do Pfizer versus Pfizer followed by Astra? It doesn't work the same way. You actually get a diminished response when you follow Pfizer with an AstraZeneca, and that's for the IgG and for the pseudovirus neutralization. And the cell-mediated immunity, that's about the same. So really no difference there. But I want to draw your attention to this. So if you just look at the Astra and compare it to the Pfizer, there's a more than 10-fold difference between these antibody productions between those schedules at 1 month at least. So pretty significant. And again, if we look at this graphically, and I'll go over, say this briefly, but if you look at the binding antibodies, again, the top three are Pfizer, Astra, Pfizer, with Astra being the lowest. That's also what you see when you look at the neutralizing antibodies. And in the other one, it's pretty much just mixed in the T cell response, which could be very important. It could be why for severe disease, Astra does so well against severe disease, because maybe it's the T cell responses that really matter for that, and not just, and maybe the antibody responses matter more for acquiring infection and a milder infection. So again, Matthew Snape is really involved. He's at Oxford, so I've let him do the ranking. But essentially, with these mixed schedules, it really looks like having a mixed schedule is the next best thing to a Pfizer, and certainly AstraZeneca Pfizer is good for producing IgG antibodies and good for cell-mediated immunity as well. The caveats to this work is, as I mentioned, it's a 4-week interval and not the recommended 8 to 12 weeks for Astra that we're using. It's in older individuals, and the live virus neutralization with SARS-CoV-2 hasn't been done yet, but that's what because it requires a special P3 laboratory, so it's more involved, but that's what the pseudovirus is meant to represent. And this isn't the only study to come out with. There's a convergence of findings. This one from Spain, where they found that Pfizer given as a second dose after AstraZeneca gave a robust immune response and had an acceptable and manageable reactogenicity profile. And this one from Germany, which is smaller studies, and the strength of the British study was that it was a randomized participant blinded controlled, and some of these aren't, but again, they come up with the same findings. In Germany, you see that the neutralizing antibodies for, if you look at the bottom, for that a V is AstraZeneca followed by an mRNA vaccine, are tightly clustered at the top, as opposed to the greater spread you get with the VV, which is Vexrexia, which is Astra. So again, convergence of the evidence, and what we have now is, Canada, Germany, France, Spain, Denmark, these other countries, as you can see there, they have gone ahead and recommended completing the vaccination series if you got AstraZeneca with an mRNA vaccine. Some of them because of this emerging effectiveness data, and some of them with that, with also the concerns about potential side effects, clotting issues with AstraZeneca. And if you want to look more at this, there's the Canadian guidelines from their ATAGI equivalent online. They do a really great job of going through the evidence, and also the German Robert Koch Institute explaining their rationale for making that recommendation in Germany.
Paul,
so with that, I'm just going to close.
Yeah, sorry.
So with that, I'd just like to do acknowledgements to those, those two people I borrowed from heavily, Matthew Snape and Mary Ramsey, and then I'll just take your questions. Ramya?
I jumped in too quickly. Sorry about that, Paul.
No worries.
It was just in relation to the studies that you were just talking about, in terms of, can we have a ballpark idea about the sample size for the studies where there were the mixed vaccines that were given?
Sure, that was 800 individuals. So not massive, but those are strongly statistically significant differences. So I think they had the sample size they need. What I will say, which this gets more interesting, they're going to bring Novavax in, other vaccines that aren't available here as well, in multiple permutations, and they're already planning the booster study, which if you had 2 AstraZeneca, what happens if you wait 6 months and you get a Pfizer down the road? So those studies are already in the works, going to yield fascinating information. So I would say anybody looking at that data, maybe going, darn, I had 2 AstraZeneca and maybe the antibody levels don't look as good. I'd say 1, it's probably going to protect you from, serious disease. And 2, you'll probably very likely one day to be able to get a vaccine of a different brand to get that boost that it seems to provide.
Sure. No, you were talking about, different vaccines coming in. There's been a question that's come through regarding the Sinovac and the Sinopharm, and how is the Sinovac or Sinopharm protection rates? I understand that these are other brands that are administered in other countries.
Yes, those are not slated to come into Australia as far as I know. I haven't tracked their performance as well because as closely because we not in a foreseeable future would we be using them. I have heard questions raised because some countries that have used them extensively have still have major outbreaks, but it's probably worth a slight diversion there. I think everyone on this call, this webinar, we need to recognize that none of these vaccines are going to create sterilizing immunity, right? They aren't going to prevent COVID from spreading once we open our borders. So what we want to do is obviously stop severe illness, hospitalizations, and deaths. That's where we want to get to. That's the minimum. If we have vaccines that also reduce symptomatic illness, that probably will play into reducing transmission, and that would be a benefit. So I wouldn't turn that down. But we need to recognize, we need to start preparing the public for the idea that we will have transmission even when we're fully vaccinated as a country.
It's a really fair point with it. Any suggestion of any new side effect profile with the AstraZeneca and the Pfizer combination?
No, there's not, and that's a good question, because the one caveat for this is we don't have a lot of safety data on these mixed schedules. But that we do know that Canada's been doing it for some time, Germany's been doing it for some time, and we haven't seen a signal raised yet. So that is a reason to hold back a little bit and let some more data accumulate. Both of these vaccines make the spike protein. So, and that's the thing that the immune system reacts to. So I would be surprised if there were a new development, but you never say never in medicine.
Absolutely, especially over the last 18 months. What are some of the, as far as we know, the long-term complications of the Pfizer and the AstraZeneca vaccination?
Well, I don't believe other than the things that occur acutely, I don't think we expect there to be long-term complications down the road that slip in. So clearly, there's been a lot of publicity about the TTS syndrome, the clotting syndrome associated with both the AstraZeneca vaccine and the Janssen vaccine, which is made the same way with a different adenovirus being used in the United States. So it seems to be something about an adenovirus vector that is triggering these clots. And of course, if you get a serious clot, one's in the brain or in the gut, that can leave you permanent disability, and then ultimately there have been some deaths. So that's important as well. And then you might have seen in today's TGA release, we've had a death in Western Australia that was reported after a woman developed ITP, immune thrombocytic purpura. It was a very, although it was treated appropriately and aggressively, the course of illness was, she could not be recovered. So that is obviously something that needs to be looked at going forward. And for Pfizer, if you haven't seen this yet, there are good data from the United States about myocarditis developing after mRNA vaccines, both Moderna and Pfizer. It tends to be young males, almost a tenfold, likelihood compared to females, but particularly that younger age group under 25. And it's suggested it has to do with the robustness of the immune system that's helping to trigger us, because it's almost all after second doses of those vaccines. So I think we need more information, but if you go to the ACIP website, they put all their slides. The investigation they released last week is available. It looked to me like we're talking 1 in 80,000 doses in second doses in those age groups. Most of these illnesses have been mild and not required hospitalization and resolved without sequela that we know of, but it's still something to be watched. And it speaks to maybe not launching into vaccinating young children in a hurry. Let's get more safety data, because those children are not at the same risk of poor outcomes from COVID infection. So the safety profile has to be very, very good to be able to justify any risk there, in my view.
Yeah, Thank you. With regards to the interchangeability of the vaccines, I guess the next question on the list is whether ATAGI would recommend that approval here, and do we know when that might happen, and whether AZ would be phased out at some stage?
Whether two good points there. Thanks for the question. I know ATAGI is considering the mixed schedules, and of course there's concern as was raised about the lack of a long safety database for the schedule. But there have been people that need to mix, right? They have anaphylaxis after one brand, so they switch to another brand. People fly in from overseas. I can tell you this from working in the health department, then they've gotten a brand we don't have overseas, and so they need to switch brands. So we're doing some of that now, mixing and matching schedules in order to get people protected. So, and I think ATAGI is really looking at what about women who got AstraZeneca and then became pregnant. We've had a number of those come to reach out to the health department and say, what do I do now? They'll get a mixed schedule, very likely. So I think ATAGI is going to decide on some of those cases within a week, I'm hoping. I don't know that it'll be broad scale switching or mixing schedules, but in certain circumstances, allowing us to do that.
Okay. And there's a question here about the interval timing between the AstraZeneca vaccine and the Pfizer vaccine. I'm assuming that question is relating to the interchangeability. So if someone has the AstraZeneca first and then the Pfizer, what would be the time frame that we're looking at?
The Germans have come out and explicitly said 4 weeks or more. And that study data you just saw was at 4 weeks. So
Okay.
with a 4-week interval between the different brands. So I think that would be the minimum that people would go to.
Yeah.
But it looks like that works based on the lab data.
Yep, sure.
Go ahead.
Sorry, go on.
Well, I was just going to say that, lab data is not clinical effectiveness data in the community. We all need to recognize that. But it, based on other work that's been done, it looks like those lab results are going to correlate with protection that we've seen with the recognized schedules. It works for the recognized schedule, so you would think it would work for the mixed schedules, is what I'm trying to say.
Yep, and that makes sense. You mentioned about some studies that are happening at the moment with regards to the booster vaccine, that, in terms of looking into the details of that. So is that looking more likely, Paul, that it would become more like the yearly influenza vaccination?
I don't know about yearly, but yes, I do think there's a good possibility we might be looking at boosters at some point in time. And certainly the countries that have gone through a real, nightmare with COVID want to make sure they don't revisit that ground again. And so that's why I think they want to have the data in hand to know that it's going to be safe and effective to give a third dose of vaccine. And I suspect that it will be. We need to see how long immunity lasts. There was some recent data that came out that said it looks like it lasts at least 6 months from vaccinations that have been done, that the T cell immune responses remain strong. So maybe it won't be necessary, but I think we want to be prepared if that happens. And we may also see a third dose that doesn't use the Wuhan strain of the spike and might be more tailored to existing variants to try and bump that coverage up from what we have now, protection up from what we have now to something higher.
Sure. You mentioned earlier on, and we touched upon this regarding the Pfizer vaccine and the risk of myocarditis, particularly in young males. With regards to that, is there any recommendation at this point in time, as far as we know, in someone who has had a medical history of myocarditis, and if they were, over the age of 60 or so, is that a contraindication? No,
it's not. And I should preface this is emerging data, but really it does look like it's almost completely in younger males. I shouldn't say completely, but that is where the signal is after second doses. So I think more what they're thinking about is, do young people need 2 doses, right? I mean, maybe their immune response is so robust that if you supercharge it with a second dose, that's where you get into trouble with maybe some cross reactivity or robust inflammation. in the cardiac tissue. So I think rather than saying we're going to extend this, I know of no recommendations to say previous myocarditis in older individuals shouldn't get an mRNA vaccine. I've not seen that said whatsoever.
Sure. I'm just skipping back over to the interchangeability question with the vaccine. Sorry for, it's going to be a bit of a long question. There is a 10 times higher risk of the IgG after the Pfizer schedule compared with the AstraZeneca one, but vaccine efficacy is considered almost equivalent with the two schedules. Is it not when 12-week schedules was used with the AZ? How would this impact on the mixed schedules?
Yes, so a couple questions in there, but taking the last point first. Yeah, well, I think to really know whether that tenfold difference in IgG spike antibodies is going to persist, we need to look at the 12-week schedule, which they're doing in that study. They did a 1 month gap, and they also have a 12-month gap. But of course, that data won't be out for a couple more months, right? Because with this data just emerged, it's going to take them a while to do it. So in a couple months' time, we will know whether the 12-month gap in AstraZeneca it looks the same, and whether the mixed schedules still appear the same. But right now, the data we have suggests that following an Astra with the Pfizer is probably not going to be bad clinically.
Okay.
Yeah, but the other point I think I should bring up there, let me reiterate that level of spike antibodies aren't necessarily what protect us from severe disease or maybe even infection. And certainly there are people with high titers that get infection. There are people with low titers that don't. So it's only one part of the puzzle. And I personally believe that T-cell mediated immunity is critically important for once you get infected, not becoming seriously ill. And that looks decent with AstraZeneca, and it may be why it gives the same protection against hospitalization and death that we see with Pfizer, even if Pfizer might be better at preventing all infections. Does that make sense?
Yes, no, that does. Yeah, it's all very evolving, and there's just the combination ones are sort of putting more mix into it now. I've got an interesting question here. So any thoughts on Pfizer vaccine following the completion of 2 AstraZeneca ones for better outcome?
Well, I think that's one of those third dose schedules we might see.
Okay.
Ultimately, I don't think we're going to rush to do that here in Australia, but depending how the data play out, and there will be clinical data now because so many countries are mixing this schedule, we'll see how they perform, in the real world environment. And if that looks favorable, that mixed schedules work as dose 1 and 2, one might imagine that 2 AstraZeneca followed by a Pfizer will also work well. And the lab data will be out from the UK in that as soon as, we'll know that data before we have to make a decision about whether that's a wise move.
Yeah, absolutely. I'm just going to skip back to a little bit about the variants, if that's okay with you. Just is the Lambda variant very prevalent in Australia?
Not to my knowledge.
Yeah, there was I don't think I've heard about it, but
yeah,
no.
Me
okay.
Okay,
I just thought I'll check.
I can't say there hasn't been a case, but I mean, that speaks to me of, I think we got to move away from the amino acid change game, right? I mean, if we did this for flu, we'd be crazy because flu doesn't have a checker the way COVID viruses do, and it mutates amino acids all the time. It does big shifts. I think we just got to realize that the natural evolution of things is there will be mutations, and they will ultimately choose the fittest circulating virus. Whether that virus is good at making people sick, virus doesn't care. It's got no emotions. It's just trying to replicate. So natural selection is going to choose the virus that replicates well. And maybe that has to do with symptoms because maybe you cough more and you spread it more. But really, these changes are going to happen all the time. We need to do what we can do, which is use our best vaccines and get our population vaccinated, and then just live with it.
Yep. It's a really fair point because that's sort of where everything is sort of heading at the moment in trying to open up borders or even trying to move on with things.
We're still in an amazing situation in Australia, right? We've got an opportunity to vaccinate our public before they're widely exposed. So it's the best position you could be in. We just need to get that job done, keep these variants at bay and get that job done. But we also, again, have to message people that we will have transmission, there will be disease. We're doing our best to keep people out of the hospital and from dying.
Yeah, and on that note, this is not a question, but it's a comment from one of the attendees. The biggest concern here again, Paul, is the mixed and confusing comments hitting media. Like you mentioned, the kind of main reason why Australia is still right at the bottom of the list in terms of vaccinations at the moment.
Yeah, there's been a lot of confusing messages. And I mean, from what I understand from the general's comments is we will be phasing out AstraZeneca by October based on the projections that they made public of our distribution. And once that's communicated, and in the context of people can see mixed schedules work really well, potentially from laboratory data, you get into a situation where it might be hard to get, there might be people who are not willing to complete the vaccination series if they think more Pfizer's available and they think it's going to work.
And maybe a bit of a political question here, but any views on the current UK strategy to open up the country?
And this is just personal. This is not going to be a health department case I say something crazy. I think it's time. I have a lot, you can tell from my accent, I'm from the United States, and I have a lot of colleagues, med school classmates. I have a lot of family. They're at the point they've been through the waves. Disease is low enough where it's not crippling society, and eventually you have to choose. Other diseases are happening. People are losing their incomes. Your socioeconomic status is the biggest predictor of your health long term. So at some point you got to balance what are the negative impacts to societies and people's well-being and their mental health and other things, and say, okay, we're going to have to tolerate this risk and burden to achieve these other things we need to in society. And so I'm not faulting the UK. I know that situation less well, but I'm not faulting it as a decision. And I can certainly tell from my colleagues and friends and family in the US that they think it's time.
Just with regards to the side effects of the vaccines, they seem to be quite similar to the COVID-19 infection. Has this all been taken into consideration with regards to the safety of approving the vaccines?
Well, yes. First, let me say that none of these vaccines that we're using in Australia contain live virus. So it's not like a measles, mumps, rubella vaccine where there is live virus. And they can't possibly even make the live virus. They basically can only encode for the spike protein the way they've been developed. It doesn't surprise me that there's a lot of overlap between the vaccine reactions and infection, because those vaccine reactions are basically your immune system waking up. When your immune system turns on, it produces chemokines and cytokines, and they give you chills and fever and muscle aches and other things. So when, I'm not being dismissive of how serious it can be. I think I'm talking to a doctor that might've had some recently, but they are actually indirectly, they're a sign that your immune system turned on. And that's the way it turns on. It doesn't know it's responding to a spike protein that's not connected to a living virus, to a replicating virus. So when you get natural infection, you're going to have some of that as well. And when you have vaccination, you're going to have that as well. So there should be big overlap until you get into the symptoms farther down the road, where fluid comes into the lungs and other things with natural infection that you wouldn't expect from a vaccine.
Well, that's handy, because I timed my Pfizer vaccine because of this webinar that was happening today, so showing example of it. But I have recovered, just so everyone's listening. All good. Probably just wrapping up with it, Paul. We've had lots of questions, so I've tried to go through as much as I possibly can. And of course, keeping in mind that we're everyone from the eastern states, it's getting quite late over there as well. You have covered this earlier on, but just to give a quick summary, if you don't mind, in terms of the infectiveness of the Delta variant, there's a query about the Alpha variant being able to infect about 4 people or so, whereas the Delta about 9. They're just wanting a quick elaboration and a summary on that.
So I haven't seen the figure 9. I've heard 6 talked about a lot from people from the UK. So that would mean in a naive population that each person with Delta would infect 6 people, as opposed to Delta Alpha being maybe 4. Again, that's important, but I tend to look at the household transmission studies and see that 12% of people in households with a Delta case become a case. That to me says something about the infectiousness. And then I look at what happened in WA. I'm going to knock on wood if this is wood. We just had a Delta variant with, someone that had quite a few exposures in the community. And we had some secondary cases, but certainly not 9.
Yeah. Okay.
I mean, maybe that shows what good control efforts can do, but these exposures happened before we even realized she was a case.
Yeah. Yeah. In terms of the Pfizer vaccine and any sort of previous history, if a patient has had open heart surgery or any troubles with it, is there still a recommendation to go ahead with the Pfizer vaccine if it is in that age group?
Yeah, there's been no change in the recommendations for Pfizer in Australia for sure, right? Overseas, I am not aware of any change, in the United States, which is led in this work. They don't use AstraZeneca, but they use a lot of Pfizer and Moderna. And they've led in this work. And for these questions, which are very good ones, I really would encourage you to go to the ACIP website, the Advisory Committee on Immunization Practices in the United States. They have their meeting. They have full videos. You can watch the whole discussion. They have all their slide sets. They're always open to the public live, so you can see the debates and you can see the evidence presented and you can see them vote on whether to create precautions or other things. But I'm not aware of any heart surgery precautions that have been put in regarding Pfizer.
Great. No, that's very useful. Thank you. And in regards to any risk of reactivation of any dominant virus that might be in the body, for example, shingles, if a patient has had a vaccine, is that a contraindication? Does that happen?
It's not a contraindication. Does it happen? I think so, based on the number of shingles cases that have been reported. Shingles recurrences can happen oftentimes when somebody gets another infection and I call it their immune system gets distracted or busy, right? And it's focusing on something else. And that's why you get even just recurrences of herpes, a different type of herpes virus, recurrences on your lip. They call them fever blisters because you get sick and then you end up with a blister, or you get too much sun and you do physical damage and you end up with a blister on your lips. So the reactivation of herpes virus seems to be correlated with stress and immune stress particularly. Mm-hmm. So it wouldn't surprise me that if the immune system is amped up responding to a vaccine, there's a chance you might have a recurrence of herpes, including shingles.
Yep, absolutely. And with regards to, again, a hard question, would you recommend that our young patients wait to receive the Pfizer vaccine rather than the AstraZeneca vaccine?
There's no recommendation for them to do so. Again, this risk is very small. And so far, the illnesses, the myocarditis have been very mild for the most part. So there's no recommendation that they not receive Pfizer at this time. I do think, though, it's important to log this, and before we go whole scale, let's vaccinate all the school kids of Australia. First, let's vaccinate our most at-risk people first. Let's get our elderly, aged care, our frontline healthcare workers, let's get them protected first, because they are where the initial disease will happen for sure. And then I think it'll be wise to allow some other jurisdictions around the world to move into these younger age groups just to get the safety database up. As I said, for young kids, their chance of a bad out from COVID is much lower than older folks, and therefore the safety profile has to be very good before the risk outweigh the benefits. The benefits outweigh the risk in those age groups.
And if someone develops a blood clot, say for example a pulmonary embolism or a DVT after their first AstraZeneca vaccination, would you still recommend the second dose?
Atagi has guidance on that, and that's available online. And they say if you've had obviously some clots, they specifically say don't get another AstraZeneca dose. It's a precaution contraindication, but it also has a caveat there. You'll see that for It says another serious reaction, and I would consider that to fall into another serious reaction, if they think it's causally linked or not, and think about getting a dose of something different.
Yeah. Paul, thank you so very much. Thank you for giving up your time this evening. And
like I said, you're a really important audience for us.
And we've been very lucky to have you on board. And I've had several comments on the chat box here that it's been very, very useful. The session has been very simple, easy to understand, and very informative. So thank you very much for giving up your time this evening.
It's a pleasure.
I hope everyone has a wonderful evening. Thanks a lot. Bye.